So we'll talk about scapholunate ligament reconstruction, which is sort of the next stage. Disclosures are the same. So we've already talked about the anatomy and biomechanics and acute injury. And so I'm going to talk about chronic instability, and I wish I had a really rosy rainbow kind of talk to give, but it's probably not realistic, so we'll give what we actually see. And I'll talk briefly about some late degenerative changes in SLAC also. So we already talked about the different stages, and basically what I want to focus on is when you see somebody who looks like this, what can we do so that they ultimately don't wind up looking like that? And is there something that we can do that actually meaningfully affects that change? So we've talked about stage 1 and 2, so partials and complete disruption with a repairable ligament. And sometimes you can get a pretty reasonable outcome, at least short term. And then we can jump to not reconstructions, which are in this stage, but in 5 and 6, where the patients either have a complete disruption that is not reducible or they have a SLAC wrist with arthritis. What happens to them, and then I'll get back to reconstructions. So the natural history is that this will, scapholunate dissociation will go on to progressive arthritis in a very predictable pattern. So stage 1, so the reason why I want to discuss this as part of the talk is if you see that you've already gotten into these stages, you're too far gone. Do not reconstruct. It's not going to work out very well. So in stage 1, at the styloid, you can have some beaking. This may be actually well on its way to stage 2. Stage 2 is along the entirety of the length of the radius scaphoid articulation. Stage 3, you've got midcarpal involvement. Stage 4, you have pancarpal arthritis. And different treatments are appropriate at different times. Stage 1, variety of different options, but arthroscopy, styloidectomy, maybe a denervation procedure. Stage 2 is where we typically wind up getting people, and a proximal row carpectomy may be appropriate, or a either scapholunate fusion or four-corner fusion can be appropriate choices, and I'm not going to go too much into why you might pick one or the other. Stage 3, it's just very clear, once you have midcarpal arthritis with involvement of the proximal capitate, do not do a proximal row carpectomy unless some people are doing different capping or replacements here, and again outside the scope. But I think personally, I think a better choice is just considering a scaphoid excision in either scapholunate or four-corner fusion, depending on your preference. In stage 4, where you have pancarpal arthritis, in my hands, a total wrist fusion is most appropriate, but an arthroplasty could be also considered, and some will advocate for those. So when do you reconstruct? So, well, you need patients who have a complete disruption with either normal alignment, or with static widening, but a reducible joint. So something that you can actually get back into the right place predictably, and no arthritic change. And so how do you assess this? Well, radiographs. So you look for scapholunate diastasis. You look for the ring sign, which is due to the superimposition of the distal pole of the scaphoid overlying the waist, and it looks like a signet ring. And then on the lateral view, you have increased extension of your lunae compared to your scaphoid, so you have an increased scapholunate angle on the lateral. Sometimes you get plain radiographs and they actually look okay, so they have normal alignment and they still have pain. They've had this injury a couple of months ago or something, and Dr. Bednar talked about you get clenched fist views and they open up, okay? And so that can be quite helpful. Sometimes comparison with the other side is also helpful. And then MRI can be quite helpful, or oftentimes I'll get an MRI arthrogram if I'm looking for a more subtle injury, and you can see that there's dye passing into the midcarpal joint. The other thing, just of note, when you're an MRI, certainly an arthroscopy is the gold standard to look at cartilage here, but an MRI can sometimes be helpful at identifying early arthritis in the radius scaphoid articulation that may push you to a salvage procedure rather than to a reconstructive type of procedure. So non-operative management of chronic instability has a very limited role. A variety of things may help with splinting or injections or NSAIDs or things, but they're treating symptoms. They're not going to correct the underlying anatomic problem, and you are going to lead to osteoarthritis over a variable period of time. And some patients will choose to take their chances on this, because if they develop arthritis in 20 years, well, that's okay, because we have salvage procedures. And so some of it becomes a philosophical, am I willing to take the risk of having a very thick chart, meaning more than one surgery, to have the potential benefit of just having this one reconstructive surgery to save my wrist. And patients and surgeons fall on different sides of this. I do think reconstruction is appropriate for many of these patients, and the key is to reduce this flex scaphoid and try to restore as normal anatomy as possible and kinematics that follow the anatomy. And so you're replicating the scapholunate interosseous ligament complex, trying to preserve wrist motion, which we heard a little bit about, and I'll talk a little bit more about, which is sacrificed in many of the procedures, and maintain this anatomic conversion back to close to normal and wrist motion as long as possible to avoid future slack. And there's a lot of different options, and we'll talk through some of them. And whenever there's a lot of different options, it could be because, like in CMC arthroplasty, everything really works. So if you take the trapezium out and you do whatever you want to do, most of the patients are satisfied, and the literature supported that. Or it could be the opposite. It could be like a scapholunate reconstruction, where there's modifications on modifications on modifications, and it's because nobody's really found that holy grail of this thing is great. But I have some thoughts. So black capsulodesis is, we talked briefly, I'm just going to go through these quickly here, is a flap of the dorsal wrist capsule. It's kept attached to the radius proximally and taken off distally and then sewn into the scaphoid. And this is a very old slide, because you can see that they have a button that's a pull through, and now we would use a suture anchor, but it illustrates it. The blat does keep the scaphoid from subluxating and corrects some of the scaphoid flexion. It does not address the diastasis between the scaphoid and lunate, and it does significantly reduce the wrist motion. And this is something that, when I was training, we did a lot of these in kids because they tolerate a lot more, but even the kids were stiff. And so I'm not a huge fan of the blat, personally. And then there's another one, which is the Mayo or dorsal intercarpal capsulodesis, and there are modifications on this. I'm just going to show you one, and there was another one mentioned at Dr. Bender's. But the dorsal intercarpal ligament is right here and extends kind of from the distal radial carpus over to the triquetrum here. You split it, and you can take the proximal strip. I'd probably have at least 5 millimeters or so, leaving it attached to the distal scaphoid, which tugs the scaphoid back into extension, and then I would suture anchor it, but you could do whatever you chose, into the lunate, and hopefully that tethers it. It also provides some soft tissue over the scapholunate interval, which may, in theory, reconstruct some of the ligament there. And you have to take the scaphoid out of flexion before you reattach, so you have the right tension. And there's it. There's another option where you can, which Dr. Benner said, you can leave this attached here, you can take this off there, and then sew this to the scaphoid, which does a similar kind of end result. The benefits of this, and why kind of these things came to pass, is because it doesn't tether you across your radioscaphoid or radiocarpal joint. And so in theory, it should allow you to have more motion, because that's not blocked as much, while still decreasing your midcarpal motion, which will decrease some of your wrist flexion in particular. It may permit a closure or a narrowing of the gapping between the scaphoid and lunate. And when I started practice, that was what I mostly did. I did those, and I was pretty unsatisfied, because you would pin it and you'd do this and feel pretty good about it and look great, and then you pull the pins out and it would go bing. And you'd say, oh, all right. And the patients were like, weren't we trying to make that smaller? And you're like, yeah, never you mind about that. That's going to be fine now. And it's just it was a little disappointing. Did keep the scaphoid up a little bit. And then there's a variety of other options. So a bone retinaculum bone or a bone ligament bone, these are variations on a similar theme. This is for patients who have just a diastasis between the scaphoid and lunate. So you're just trying to reconstruct that dorsal scapholunate ligament. They don't have the significant flexion. One option for this is to take a bone block from Lister's, which is left with the periosteum and the retinaculum on top. I'm going to show you even bigger. You take a chunk out of it in the middle, so you make it sort of soft in here, so you have a bridge of soft tissue between the two. aka your new ligament dorsally, and then you can plug it into bone troughs that you make, and then you screw or fix these in some manner. So it's kind of a nice idea. And that can also be done with a bone ligament bone for the base of the second or third metacarpals. You just need to have 2 bone plugs with a soft tissue connection. And that can be done. It's really indicated for pretty normal alignment with just a complete scapholunate tear. And again, these sort of work kind of okay. And then a Brunelli. So when I was pretty unsatisfied with the Mayo dorsal carpal capsulodesis, I started thinking about what else to do, and Brunelli was relatively appealing. And so the Brunelli was initially described as you take a strip of FCR, you can take half, or that's usually plenty, and you split it longitudinally up to its insertion distally on the index metacarpal base, and then you make a drill hole across the distal scaphoid and then pass the half of the tendon from the volar scaphoid tubercle out the dorsal scaphoid. And the original was, again, sewing it into the radius here, which kind of was back to a blat. So you've now tethered your radicarpal joint. And then people made modifications on that and said, well, maybe we should go over to the lunate. And so that's what I was doing. You can go to the lunate, and then there's modifications on how you get it sewn in there in a variety of ways and how you make your tunnel. But the short of it is there's a tunnel through the scaphoid. And so there's a bigger view just so if you can't see the pictures. And this actually was pretty good. It was excellent at correcting the scaphoid flexion. The scaphoid is not going to flex back down again because once that tendon heals into the scaphoid tunnel, the scaphoid is not flexing. The issue is that the scapholunate interval does gaps usually, again, because you're just, again, laying some tendon down on top of it and kind of hoping that that's going to become a strong enough stabilizer, which sometimes it's not. But they seem to have better flexion than the capsulodesis, and even though sometimes I did have gapping again, I wasn't that displeased with it, but I just didn't really feel like, wow, this is the thing that I want to do. This is not then where I went, but this is another option. So Erasol, and Erasol has kind of a nice name. It's, SLAM, and they have a lot of sort of marketing types of names, but Erasol is basically reducing it and putting a headless compression screw across the scapholunate. And this had some popularity with other people in my geographic area, and so we would see some of these. They would come over because people always get different opinions because they're sometimes unhappy with their scapholunate no matter what is done by anybody. And the problem with Erasol is, in theory, if you have it exactly on the right axis, these 2 bones sort of move together. But the reality, and if one of my partners does a great, yes, he does this dance, and I'm not going to do it too well because I'm not really that good at it, but you start wiggling a little bit, and then suddenly you're wobbling, and then the whole screw has eaten out the entirety of the lunate and the entirety of the proximal scaphoid, and you say, this is a mess. And he has this whole dance, but you can picture it. It's pretty nice. And then it's kind of hard to get the screw out because it's just flopping in the middle of the bones, and it's sort of a mess, and you don't have anything, you have no bone to key in for any of your fixation if you wanted to do something different. So I wasn't really wildly happy with seeing these, and luckily they seem to have gone away mostly. And so in addition to all of these, there's a lot of different modifications. There are many articles, and it's because people are really struggling and striving to try to find something to fix this problem, which we all agree is a problem, and we just haven't really been able to find out what to do about it. From any of these capsulodesis or tenodesis, the range of motion is typically on the order of 60 to 80%. You lose more flexion if you cross the radicarpal joint with your reconstruction, less if you don't. Grip strength is diminished, and it's kind of, as Dr. Benner pointed out, it's kind of in the salvage procedures. And so, some patients will say, I don't really understand what you're talking about. You're going to do these, and I'm going to be sort of not really any better than I would be if I just didn't have surgery and waited 15 years and just did it whenever I got really painful and arthritic. And you say, So you're like, okay, so that's that. Until more recently, and I don't have long-term follow-up, and I don't work for Arthrex who's doing this, but I think this is kind of a very intriguing option, as probably everybody who's done all these other intriguing options have thought, but maybe not. Maybe this is actually something different. I did, at the risk of looking, I don't work for Arthrex, but I used some of their pictures because I don't have a lot of these on my own, and I didn't put the whole thing in because I didn't want this to look like a techniques manual, but you do a dorsal approach and you can do whatever capsular incision that you think is most appropriate. And you get joysticks in both the scaphoid and the lunate, and you try to keep them out of your way. And then you bookend this open. So you're looking directly on the scapholunate articulations where the two bones would kiss together if they were reduced. And you make some tunnels. And you make a unicortical tunnel in the scaphoid here, and you bring them back together and measure out where it's going to be. And then you make a similar tunnel in your lunate. That tunnel is connected to a second tunnel, so if anyone's done some elbow surgery where you're going to take two drill holes and connect them together, it's a similar type of process. And you're making a bicortical tunnel that you're going to pass your graft through here, but a unicortical that you're going to secure it to right here. So you get those prepared, and then there's a third one up in the distal scaphoid I'll talk about in a second. You select your tendon graft. I have done this for, 4 times, so I don't have a ton of experience, but the key with this, and I think some of you did some of this yesterday, maybe in the lab, but it's got to be a skinny graft, and it looks ridiculously small when you take it, because we're used to taking half FCR, and you feel really great about it, and that's terrific. And you take this thing, and you're like, this is ridiculous, this is not going to work, but you're supplementing it with a non-absorbable suture tape, and I use labral tape, which is probably what most people use for this. Try to get a long graft. I mean, it can be shorter, but you wind up getting a little tight, so I'd just take 10 centimeters, and you'll be fine with that. And I've done 2 with palmaris and 2 with a strip of the radial wrist extensor, and it's really dealer's choice, whatever you feel like you like. The benefit of the radial wrist extensor is you've already got your incision there. Palmaris is a freebie. It's up to you. And then you take your strip of tendon and your suture tape and have them together, and you dunk them into this tunnel with a forked swivel lock. So it pushes those down in, and then you insert this interference screw over top. And it is really quite strong. It's very nicely secured. You then pass the tape and the tendon up through this and out the dorsal lunate. And when you tug on that, those bones will come together in a way that's very surprising, actually. It achieves a really nice compression. You can compress it additionally with your joysticks, etc. And then you put a second compression screw in here. So you have your tendon graft, but it's supplemented by this sort of an internal brace of the labral tape, which is nice. While your graft is incorporating, it also doesn't allow the graft to stretch because the labral tape's not going to stretch. And then this is already reduced, and that part's then done. You can, if your scaphoid needs to stand up anymore, you can do that. And then you take your graft and your tape over to that third hole in the distal scaphoid and use another swivel lock, which has the forked end, so it pushes the graft and the tendon down into it, and then you put your last interference screw there and just cut off the extra. And they recommend doing a scaphocapitate pin, and because I don't know any better, I haven't modified that yet, but it seems very reasonable, and leave it 6 to 8 weeks, whatever seems right to you. And this is what it looks like in the end. And this is a case I actually did Wednesday this week, and it's really nice. You get this, and this is without the pins not in yet, you get this really amazing tightness. It's nothing's holding it. It's just holding itself at this point. And then this is the graft and tape going from the green arrows looking at the dorsal lunate, and the red arrows going up to the distal scaphoid. So that's that dorsal part, and the other part's in between the bones that you can't see any longer. And it's actually very satisfying. So this is one of my patients that I've done this for. You can see there's diastasis, there's increased raised scapholunate angle on the lateral, there's no arthritis. MRI shows complete rupture and no significant arthrosis. And then this is it afterwards, so you can see where your tunnels are. So I mean, I think there is certainly going to be concern for AVN or fracture. But you get a really nice repair, and with very short-term follow-up so far, they seem to be very good, surprisingly so. So you have to see in a year or two what these actually show. So in summary, wrist kinematics is complex. Scaphoid, it follows a very predictable pattern. It involves both intrinsic and extrinsic injuries. And try to treat them early. So recognition is important, but as Dr. Bednar pointed out, frequently they don't show up that early. And once they're in the late degenerative stages, reconstruction is not appropriate. But there is a sweet spot in between where scapholunate reconstruction may actually save their joint. And I think that's something to try to achieve. So we can take somebody like this and head them in the green rather than in the red. Thank you.